I'd like to thank Ovarian Cancer Australia for giving me the opportunity to talk today. It's very easy as a doctor, just to remain in a little clinic room and just sort of talk to the person in front of you, to when you're doing your research, sort of sit in your research environment. But really, nothing. What we do is sort of meaningless, really, unless we're actually really able to get all that information out there, and not only that, use that information, whether it be from the research or from a clinical practice, to help women either manage risk or actually manage the cancer that they've got. And it really is I have to say, it's a wonderfully exciting time to be in this field of genetics, with the explosion in technology, which has really given us the power to be able to test cheaply and quickly, not just one gene but multiple genes at a time, has really now given us the opportunity to start using this information on a daily basis to help treat women with cancer. In the past, I don't know if any of you have ever been through genetic testing. Sometimes it could almost be a year from blood draw for a gene test to get a result, and that was one or two genes done at the same time. Whereas now we can literally and routinely get those test results back in about 4 weeks. If we really have to, we can get a result back in just over a week. So it has made a tremendous difference to the way that we integrate and use genetic information. And really, today's talk is a little bit just to sort of bring everyone, hopefully, up to speed about where we are with the genetic understanding of ovarian cancer, and in particular whether BRCA genes fit in with this. And not just in terms of just giving a sort of fairly dry old talk, it's this level of cancer risk and this level of cancer risk there. It's actually about how we're actually using this information on a daily basis now, in terms of helping women either manage that risk or in terms of their treatment options. So I'd like to sort of start in a sort of slightly broader sense about why is hereditary cancer, or thinking about the hereditary basis to cancer, important. I think the easiest thing to say is for the families at risk. It's important because they have a high burden of cancer. So for the families that have got this genetic predisposition, the cancer risks are very, very, are high. And so it's really important for those families that we know about them and we can focus efforts on them. And we can actually reduce either cancer happening or pick it up earlier, so that women or whoever else has got the gene mutation are less likely to die from the disease. But it does actually, the hereditary basis of cancers does form an important proportion of all solid tumours. So with ovarian cancer, it's probably somewhere at least 20% of the common types of ovarian cancer have a hereditary contribution of some type. Breast cancer is possibly a little bit less, maybe about 15%. Bowel cancer about 15%. Some other tumours of the hormone type glands that might even be higher, maybe nearer 30%. So the contribution is actually quite high. You can start thinking then that if we can, on a population sense, almost in a sort of countrywide sense, identify those families that are at risk, you can see that those families actually contribute a lot of that average population risk. So when we're thinking about, we all use this figure, 10% of women, all women have a 10% risk of getting breast cancer over their lifetime. That figure actually isn't correct. That is an average figure, and some women have a much higher risk than that, and a lot of women have a much lower risk than that. But that's the average for the entire population, and that's how we've developed our screening programs, our breast screening programs, taking that average risk, thinking of over on the population. It's worthwhile putting all that time and effort into breast screening. But in fact, would we be better actually identifying those women who are at somewhat higher risk and those at somewhat lower risk, and maybe those at lower risk either don't need mammograms at all, or they might only need their mammograms every 5 years, whereas those at the much higher end of the scale should be having their mammograms every year. So can we actually start using this information to try and personalise, even on a population-based level, an approach to cancer care? And that's really where this slide sits, that there's some families who have got a disproportionate burden of cancer risk. It's important for them to know who they are so we can focus efforts on them, but it's also important for society that we stop thinking in the generality and that we try and start sort of splitting the population up into different risk groups so we can actually use our overall resources more effectively. And then really we've got a good chance then of actually bringing the overall cancer burden down, either in terms of diagnosis or certainly in terms of cancer, shortening people's lives and affecting society in that way. So how can we use this information? Well, first of all, we have to identify people, and then not only do we have to identify people at risk and their families at risk, we also have to be able to provide them with the necessary strategies to manage that risk. There's no point finding someone at risk and they're not being able to do anything about it. And so that means that there has to be the resources to actually be able to access those things, and we also have to provide ongoing support to people, because either advice changes as scientific knowledge changes, or people frankly get a bit sick of the idea of having to be screened all the time. They do it in a first flare of enthusiasm for the first few years, and then it all sort of fades off. So there needs to be a little bit of sort of gentle encouragement to sort of keep people on the straight and narrow. The sort of term for it, technical term, is screening fatigue, and certainly you can imagine after a few years of going every year for, say, colonoscopies, if you've got a risk of bowel cancer, it certainly loses its appeal. So that was a sort of bit of hand waving in a general sense, but coming on then to sort of the specifics of the talk about where do the BRCA genes fit in with ovarian cancer. Well, the first thing to say is when we talk about, you've got the BRCA gene, we're all being a bit slack, certainly in a medical sense, about that term, because in fact it's not the BRCA gene itself that's the problem, it's a faulty BRCA gene that's a problem. And the BRCA genes, we all have them. And BRCA stands for BR for breast, CA for cancer. One we found first, two we found second, and if we ever find another one, it would be BRCA3. And there is a tendency for us to try and use the word BRCA rather than BRCA, although we all sort of end up slipping into the BRCA, just because one of the American companies that likes to think that it owns the patent and they're the only people that can test for this in the whole wide world have patented the name BRCA. So we'll just try and use the word BRCA if we can. But anyway, BRCA genes, we've all got them. We've got 2 copies of every gene. For a bit of basic genetics, we inherit 1 copy from our mother and 1 copy from our father. So we've got 2 copies of a BRCA1 gene and 2 copies of a BRCA2 gene, and we're all born with those. And the normal job of our BRCA genes is to basically detect and repair the important types of DNA damage. Our DNA, our genes are being damaged all the time by living, whether it be the sun, whether it be smoking, whether it be general environment, poor diet, or even if you do all the right things, still the very process of living means our genes are under attack. And we've evolved very, very important ways of repairing our DNA. And one of the most important ways of repairing DNA as accurately as possible is through the BRCA-mediated pathway. So you could imagine if your BRCA genes are not working as well as they should, that means genetic damage that is happening starts to accumulate, is not repaired properly, and eventually enough DNA damage is acquired. Either the cell dies, which is frankly probably preferable, or it transforms and limps along and becomes a cancer. So when we talk about someone having a BRCA gene fault, what we mean is they have inherited a fault or a mutation in one of their copies of either their BRCA1 or their BRCA2 genes. The other copy of that gene is normal because they've inherited that copy from their other parent. So in every body cell, they will have 1 functioning normal copy and 1 faulty copy. Now that's fine actually, because human being, our evolution has been very clever. We actually don't need 2 working copies of our BRCA genes. In fact, in a lot of our genes, we only need 1 working copy. But what happens if the remaining normal copy gets damaged? And that is that's the thing that starts the whole cancer process going. If your remaining normal copy gets damaged in a breast cell or an ovarian cell, then that cell has no functioning BRCA1 or 2, and that's when cancer can start to happen. So right from the beginning, you can see that if cancer happens, the genetics of the cancer are very different from the genetics of the rest of the body, because the genetics of the rest of the body still has, the cells in the rest of the body still have a functioning BRCA gene, but in the cancer, it no longer has functioning BRCA. And I'm sort of really emphasising that point because I'll come to later in the talk that we're using this different genetic makeup now between the tumour and the rest of the body as a way of maybe trying to harness those genetic differences to target new cancer treatments. Now, I'll just make a statement first of all that we now I've got good evidence, and here in Australia it was the last sort of nail in the coffin about in terms of understanding the contribution of faulty BRCA genes to ovarian cancer. 18% of serous ovarian cancer, that's the most common type of invasive ovarian cancer, is linked to BRCA gene faults. And that's so in Australia, a number of women, I think recruited between about 2008 and 2010, I think, were recruited into the Australian Ovarian Cancer Study. So these were women with, regardless of family history, had a suspected diagnosis of ovarian cancer, were recruited in all the major centres in Australia, and donated blood as well as a piece of their tumour, which has underpinned so much research in Australia you wouldn't believe. But we also, as a consequence of that, went back and tested 1,000 of those women, which is about as many as we actually still had DNA available for, and to try and see how many of them had a BRCA gene mutation. And 18% of those with serous ovarian cancer did. So that's just sort of put a little bit of a context on that, leading in to a little bit of a sidebar, but something that's given us a great injection of enthusiasm into the familial cancer community, but it was also a bit of a rod for our own back in terms of the amount of work that it's created in the last few months. Now, these slides are courtesy of Associate Professor Paul James, who's a geneticist that works with me at the Peter Mac and also at the Royal Melbourne Hospital, and he's been looking at the data of the amount of women that have been referred in to genetic services, not just here in Victoria, but also in WA and in Queensland, as a consequence of Angelina Jolie's announcement earlier on this year that she carries a BRCA. She has a BRCA1 gene mutation, and as a consequence of that, chose to have her breast removed and have a double mastectomy to prevent herself getting breast cancer. And she wrote an absolutely beautiful piece in the New York Times. And if anyone has got any interest in looking, I would look at it. It's beautifully written, very well balanced. And unfortunately, I'm just going to go ahead. I'll come back to it in a minute. Let's go back previous, because not all of the things that came out after that were as well balanced. Let's put it that way. I'll come back to that in a second. So Paul he went to the internet and he managed to put together her family tree from what's publicly available. And basically what we have here is Angelina Jolie, and she's got 3 genetic children who share her own genes, biological children, and 3 adopted children. One brother, and her mother died of ovarian cancer at the age of 48, but previously had a diagnosis of breast cancer. We're not quite sure at what age she developed that. And just more recently, her maternal aunt died of breast cancer in her early 60s, and their mother, so Angelina's maternal grandmother, died of ovarian cancer in her late 40s. So as a consequence of that family history, which is a very classic, strong family history, which immediately rings alarm bells that there could be a BRCA mutation. At some point, someone in the family had had a gene test, and then she subsequently had a test of her own. And in the New York Times, she, as I said, very beautifully did describe how her mother's death impacted terribly on her, and that she quoted the top end of the risk scale, I have to say. So this 85% risk of breast cancer, I have to say, not all women have got such a high risk. Some of the risk could be as low as 40%, depending on the person's ethnic background and the strength of the family history. It could be 40% rather than 80%, but still raised. And her decision to undergo the mastectomy, and really sort of laboured the point that the information gave her power to make a choice about what to do. She wasn't saying women should have their breasts removed, but just it gave them power to make a decision. Unfortunately, despite that very, very well-balanced piece, that a lot of the more tabloid approaches after that were really much more sort of scaremongering, really, and really just focusing on the idea about having Angelina Jolie having her breast removed. But there was an immense amount of media interest, and that was just what Paul put together through linking with the WeHi media group, showing that over that period of time there were multiple articles. But this is what it did to us physically in the clinic as a consequence of that publicity. So when you look at this chart, each coloured bar is a different clinic, and the pale blue is the Royal Melbourne, purple is Peter Mac, green is South Australia, red is Westmead, and the blue is Prince of Wales. And so these are the sort of in weekly referral rates of new patients into our clinics in the 5 weeks leading up to Angelina Jolie's announcement. And look what happened after that. So we sort of tripled our activity in terms of referral rates coming in during that time. And it's now settled down to a doubling of referral rates. But in itself, although you think, oh my gosh, the biggest concern we all had was not that people were then looking at their family histories and concerned about their risk, is was there scaremongering? Were women who weren't at risk being the ones who were ringing up and being worried when they just had one relative or distant relative had breast cancer at a much older age? And what these two pie charts show us is that in fact the people that came in were the right people still. So this was before Angelina Jolie's announcement. The sort of dark brown is the people who when they come in are considered at a potentially higher risk through a nationally accepted grouping of risks, and about a third are considered moderate risk, and we get a little smattering of people who are very worried but actually don't have much risk at all. And after Angelina Jolie, although we got a little bit of an increase in women who didn't have much of a risk, in general the right people were still coming for advice. So I think it's been a good thing. So it's been a good thing that people have looked at themselves, but it has certainly made a big difference to us in terms of workloads, and certainly we've gone from having no real wait list to seeing people to a wait list that's now we're booking into March, and if new people come in, get new referrals, we'll be probably booking into April before very long. So going back to the BRCA and ovarian cancer, so awareness is high, and it's not only the right people come in that might not have been aware. I have to say that it's made explaining things to women a lot easier. I think this Angelina Jolie, I think, is at the end of a wave of public understanding about the positive contribution of genetics to disease in general and to risk in general, not just even cancer. When I started in this field in the late 1990s, there was a lot of suspicion and concern, both in the general public level, at the general oncology level, about making people worried unnecessarily. What are we going to do about it? Are we going to create a vast amount of uninsurable people? Are we just going to disturb people's peace of mind? Isn't it better just to let things happen as a matter of course? And also, I think a little bit about this general sort of subconscious level of fear of genetics and what that means. Somehow eugenics gets involved with all this. There's a lot of things that people can't necessarily put a finger on, but just make generally a bit worried and suspicious. That has changed dramatically, and I think Angelina Jolie is almost, again, the final pinpoint in that is that I think there is a general embracing now in the general community about the power and usefulness of this information. Yes, it might come with some concerns for individuals. Yes, it might be unwelcome information, but the fact is, it's there. If the gene is there, it's there, for most people, it's a case of it's better to know than not know. So going back to the Australian ovarian cancer study, so I said about 18% of women were found to have a mutation. But even more importantly, just about half of those women that we found a mutation in did not have a recognisable family history like the Angelina Jolie pedigree that I showed you. Now, it might be that when you then unpick it or go into more detail, there's more of a family history than they either reported at the time they entered the study or were aware of. But certainly that was the family history they were aware of when they presented with their ovarian cancer that they reported to us. So if we just ascertain now or pick people for testing on the basis of their family history alone, you can see that we're missing half the people. And even those that were sort of, you could say, well, that family history is somewhat suspicious, very few of them had actually been referred on or at least had attended a familial cancer clinic. It's hard to know if there was any discussion at the level of their own oncology clinic and they had chosen not to be referred, but certainly very few of those women had ever made it as far as a clinic like mine. We'll say that, just by looking at ovarian cancer, you can see it doesn't matter what your family history is. The fact of having ovarian cancer in itself is usually enough to trigger the idea of thinking about testing. But there are also, as well as family history, though, there are some other features that do make us think particularly that could there be a BRCA mutation present. And that's that people with certain ancestries have got a slightly higher risk of having a mutation before we even start. And it's all to do with mixing of gene pools. So people with Ashkenazi Jewish ancestry or come from various different Scandinavian countries, people with Polish ancestry, French Canadian ancestry, there's little what we call founder mutations. In other words, a gene fault that's much more common in those particular populations, which for a start helps us target our testing, but also raises the threshold before we even start, or the suspicion before we even start that a mutation might be present. So what does having a BRCA mutation mean in terms of cancer risks? Well, so I'm saying I think the range of breast cancer risks, broadly speaking, the risk of getting ovarian cancer with a BRCA1 mutation sits somewhere between 40 and 60% over a lifetime. BRCA2 mutation somewhere between 10 and 30% over a lifetime. The reason there's a range is it depends how we select the person to have a test, because different groups of people will have slightly different levels of risk. But just to put that in context, and you might all be aware of this, the average risk of getting ovarian cancer in the general population is a 1% lifetime risk. So even when we're looking at the BRCA2, it doesn't look like it's a very high risk, but it's quite a large risk in comparison to the average population. And the breast cancer risk, we sort of quote somewhere between 60 to 80% over a lifetime. There's also a raised risk of other cancers, more with the BRCA2 than with the BRCA1 gene. So prostate cancer, male breast cancer, pancreatic cancer in both men and women, and melanoma are raised. There's still a lot of debate about how raised these are above the average population risks, and it probably is location dependent. So in Australia, we don't really see a raised risk of melanoma because the background melanoma risk for the whole population is so high. But in other countries where the background melanoma risk is not so high, we do actually see a slightly increased risk. So why is knowing about a BRCA mutation important? Well, it's important, certainly for women with ovarian cancer, on a number of different levels, for them as individuals. For a start, knowing that the BRCA mutation has been part of the reason for that ovarian cancer developing tells us that overall, women with BRCA mutations compared to those without a BRCA mutation do have improved survival, slightly more likely to be cured, and if they're not cured, still live longer. And that's because they have improved responses to chemotherapy. So this comes back to this idea that the tumour is genetically different to the rest of the body, and the tumour does not have functioning BRCA genes. As a consequence of that, it cannot repair the damage that cancer treatments do. So cancer treatments often work by damaging the DNA of dividing cells, and often cancer cells get around that by finding a way to repair that damage. But BRCA-caused ovarian cancers don't have that, are already impaired in terms of trying to get around the chemotherapy effect. So we certainly see that even the standard agents, things like the platinum agents, which are the mainstay of a lot of ovarian cancer treatment, then the second line treatments, the anthracyclines, the doxorubicin based type treatments, we also see an improved response rate. In other words, the proportion of women who are going to respond to that treatment is greater if they come from a BRCA linked ovarian cancer to those that don't. And then even more sort of excitingly, really, we're now trying to develop targeted agents that specifically work on that genetic difference. So I mentioned already that cancer cells are clever and they find other ways around things. So even with a BRCA mutation, they can still find a little way around that by upregulating other pathways of DNA repair. They might not be quite so good, but enough maybe to keep them alive. So what we have is we've now got trialling new drugs called PARP inhibitors, and the PARP pathway is one of these secondary repair pathways. And so if you give a woman with a BRCA gene mutation who's got ovarian cancer or breast cancer a PARP inhibitor, we find that they work extremely well in terms of response rate. So this is women whose cancer has returned. If you give that woman a PARP inhibitor, we see somewhere between a 50 and 60% response rate after they've failed on after their tumour has found their way around the standard treatments. Now that is an almost unheard of response rate in that setting, and that's because we're attacking the tumour in a different way. But even better than that is that the rest of the body cells are not really affected by those PARP inhibitors to any great extent, because the rest of the body cells are still using their BRCA pathway. So what we have is a BRCA pathway in the normal cells, no BRCA pathway, but a dependence on PARP inhibitors in the tumour cells. So if you can tackle that second pathway, you can have an important effect on that with very little effect on the normal cells, which are hardly using the PARP pathway at all. So you think of the BRCA fault as the Achilles heel of that tumour. You might think, so the irony is it's the BRCA fault that caused the cancer, but it's the BRCA fault that then opens another line of therapy. So a consequence of that work that came out of the Australian Ovarian Cancer Study is that there is now a change in the national guidelines that all women with invasive ovarian cancer should now be eligible to have a BRCA gene test, regardless of their family history and regardless of their age of onset. I think the only group of women at the moment is if a woman develops ovarian cancer in her late 70s or 80s with no family history, and lots of women without cancer, whether or not she would have a test is another matter. But certainly women well up to the age of 70, regardless of their family history, would be eligible for a test. And that's because it's a good way of finding new families with BRCA gene mutations, so we can focus on their other family members as well. It gives us important information for that woman's cancer in terms of both her likely outcomes, and also what treatments she might be offered. And it also means that she might well be eligible for other therapy trials if her cancer should come back. The final thing that we want to do is because there is such a difference in survival, we think it's really important that any new trials of cancer therapies should have as their sort of basic, sort of what we call stratification factors. In other words, what has to be taken into account in terms of the interpretation of those trial results should include an understanding of BRCA mutation status. Because if having a BRCA mutation means that you will handle the drug or respond to drugs differently and have a different survival, if you don't know how those women are distributed amongst the different study arms, how are we going to possibly interpret how those results, what those results mean? But we've talked a lot about treatment, but prevention is obviously key. Although we do have reasonable treatments for ovarian cancer, too many women with ovarian cancer do not survive their ovarian cancer. And until we've got something revolutionary, such as PARP inhibitors or possibly something else as well, really, we just want to try and stop women getting ovarian cancer in the first place. We don't want to be trying to cure something that's difficult to cure. So because all women now with invasive ovarian cancer are eligible for a BRCA gene test, that is really important way into their family members. So we can identify women who don't yet have cancer as being at risk or not. And for those that are at risk, what can we do to help protect them? And certainly the most effective way of preventing ovarian cancer is to remove their fallopian tubes and ovaries, because the fallopian tube is also at risk. It's not just the ovary. Think of it as a sort of combined organ. And also for women who are certainly at risk but not quite ready to go into menopause, because of course taking out their ovaries will put them into menopause. There are some women who finish their families in their 30s but aren't quite ready to go into menopause and would like to hold off for a few years, which is fine from a risk point of view. We're also looking now at whether instead of just having a simple tubal ligation as a form of contraception during those years, actually remove their fallopian tubes to see if that will minimise their risk to a degree. Of course it doesn't take away all their risk, and of course they will still be advised to have their ovaries taken out at some point during their 40s, but might give them a few temporising years to get them to that point when they're ready. But ongoing research is absolutely key. We need to find other gene mutations, because we know the genetic contribution to ovarian cancer is not just BRCA. There are other genes that we've found a few of them. We're just trying to work out how to use them at the moment, but there are others still. That's the inherited risk, but of course a lot of women will develop ovarian cancer not because of an inherited risk, but something has still gone wrong with the genes of an ovarian cell to allow it to become a cancer. So not in an inherited form that they can pass on the risk, but still enough that cancer's occurred. So we also need to find for those women what mutations have happened in their tumour. And the reason that we want to do that is so that we can then find better targeted treatments and personalised cancer therapies, rather than just that everyone gets platinum or everyone gets this, that or the other, or everyone has radiotherapy. And we also have to understand how metastatic disease develops. In other words, how do ovarian cancer cells move around the tummy, move around elsewhere? How do they get the ability to lodge somewhere else and grow there in that place? Because if you can start trying to understand how those things happen, again, you can try and find ways to actually overcome it, which will greatly increase the chances of cure for those women that do develop ovarian cancer. So we have to find new targeted agents to personalise therapy. We have to find new ways of delivering current treatments, either by route, and some of you may have participated in some of these new intraperitoneal chemotherapy trials. Instead of just into the blood, we actually put chemotherapy into the tummy. And also new ways of delivering current treatments, so the treatments that we already know of, but should we also give them in a different way? In other words, do we have to always give it in that 3-weekly cycle? Is there different ways of giving it? Can we just trickle it in a little bit more over time? Or even once women have finished the standard group of treatment, should we be giving a little bit of maintenance treatment, maintenance drugs, maintenance chemotherapy in a way to keep cancer cells at bay? So I feel I've sort of galloped through the whole of sort of genetics of ovarian cancer and how that might impact onto treatments. And as you can see, I am quite enthusiastic, and I just talk a bit more quickly as time goes on. But hopefully it didn't make your head spin too much. But I'm happy to take questions at the end, because I'm conscious of the fact that Karen's got to go. But keep those thoughts in mind, and I'll speak to you after Karen's finished. Thank you.
That's the first time I've heard you say that. Hi everybody, how are you going? My name's Karen. I'm actually going to talk to you. I don't have slides, but I wanted to talk to you about my journey. Gillian has pretty much described a lot of what we went through. So we were actually, my aunt was diagnosed first with ovarian cancer. At the time, it was thought that it was an isolated case. And she was diagnosed, actually she was opened up by a general surgeon down in the peninsula, where they discovered that it was actually ovarian, quickly closed her up and then sent her to Monash to be correctly diagnosed and operated on by Professor Tom Jobling. And so from our point of view, we looked into it. We didn't realise the impact of familial connection, and the reason that we didn't really focus on that was the fact that my mum had actually had a hysterectomy. Now, as being a 1930s woman, when her doctor, who was a leading professor at the Mercy Hospital, had actually told her that everything was taken care of now, she didn't have to worry about anything, we didn't realise she had ovaries left behind, which is quite common with regards to hysterectomies. They're usually partial hysterectomies, and the ovaries are left behind for a natural menopause. So some 5 years later, our mother was also diagnosed with ovarian cancer, and we were quite devastated. And I guess from our point of view, the way to get around that was to actually found an organisation that could actually disseminate information to families like ours, and to give them the crucial information about familial connection and also the signs and symptoms of ovarian cancer. Hence, Ovarian Cancer Australia, or as it was known then, OVCA, was actually created. So we, as a matter of connection, we went to the Peter Mac Familial Cancer Centre under one of Gillian's colleagues, Marianne Young, and actually had a discussion with Marianne about potentially having a gene test. So they looked at the family history, and they knew that mum's sister and mum both had the disease. And in those days, it was thought that 4% of women with ovarian cancer actually had a familial cancer gene. So Gillian has explained that it's now 18 and possibly higher, but certainly in those days it was 4%. And so we actually had the discussion, and it was actually thought that it was two isolated cases, and there wasn't any other familial connection previous to my mum and her sister, and so therefore it was probably not a genetic mutation. My aunt, her journey was 11 years and 10 months with ovarian cancer, and my mum was 2 years and 10 months with ovarian cancer. My aunt totally didn't want to know anything about genetic testing and pretty much closed down, to the point that I actually promised her if something happened to her, I would actually speak to her family, because she didn't want to acknowledge it, and she certainly didn't want to have to explain it to her family. And not everybody copes well with that kind of information. So that's one thing that I will actually put out there. Some people want to know, and they want to know lots of information. Some people are happy not to know. My mum, on the other hand, always believed that there was a reason why her and her sister both had the disease. And just to give you an overview of both sisters, my mum's older sister was actually the wife of a horse trainer. So she was up early in the morning, she smoked maybe 2 packets of cigarettes a day, drank alcohol. My mum was a larger lady. She also didn't smoke, and she also didn't drink. In fact, she'd have a glass of champagne and she'd be on the ground giggling. So completely different lifestyles. So my mum really believed that both sisters having the disease was not a coincidence. And thankfully, through Kelly Phillips, was mum's medical oncologist, thankfully through Kelly, mum asked to put blood away, just in the occasion that in the future that it would actually be tested, which was extremely lucky, because obviously to do a BRCA test you actually have to test the gene, the blood of someone who has actually already had the disease. So 9 months after my mum passed, we actually her blood was tested, I'm very happy to hear that it's now 4 weeks, but in those days it was 9 months. So you can imagine sitting on the edge of your seat for 9 months. But yeah, it came back and it actually showed a positive predisposition for BRCA2. So that pretty much changed everything, that the way we thought about things. And through the assistance of Marianne Young, who's the familial cancer counsellor at Peter Mac, we then set out to actually have individual tests. So my mum had 2 other sisters. Both of those were tested, as well as her 2 other brothers. And from that, believe it or not, the 2 boys actually didn't have the gene. One of mum's sisters did have the gene and one didn't have the gene. So the one with the gene actually went and had a total hysterectomy straight away. That was her response, and that's what she wanted to do. There's a different school of thought amongst our clinicians as to whether it's a total hysterectomy or it's just the ovary and the fallopian tube removal. But that is, again, the power of knowing that you have choice. And so Nicole and I were also tested. My sister Nicole Livingston, some of you would know her, Olympic swimmer and a media person. So we went in to actually get our results. It was a bit of a nerve-wracking day. She was actually hoping that she had it, not me, and I was actually hoping that I had it, not her. And as it turns out, we came out. We went into separate doors. You were with me, I think, and we actually had the consultation. And when we came out, we both nodded at each other and both realised that we both had it. So we both have that gene, and I just want to really emphasise the fact that that decision to have the gene test and that knowledge that we have is probably the most critical piece of information I've ever received in my life. I don't want to get emotional about that, but really because it actually gives you choice and it gives you power. I've had a lot of women actually say to me over my years with Ovarian Cancer Australia, I don't think I want to know. And what I've always said to them is that knowledge is power, and I've always applied that to my life. And I believe the fact that about 7 years ago, actually no, hang on, I'm 48 now, and when I was 36, not long after Mum passed, and we knew that I had the gene, I was having a routine test with Professor Michael Quinn at the Peter Mac Familial Cancer Centre, and they found a cyst. And so Michael's recommendation was that, and I'll never forget the day, because normally I just sail in there and, hey, how's everyone going? It's wonderful, isn't it? And, you know, treat them like my friends, because I feel like it's family there now because we've been for so long. And I remember Michael saying, I'll come and sit next to you, Karen. Kelly, you can sit on the other side of the table. I'm thinking, well, that's really weird. He wants to sit next to me. How nice. But then he actually said to me, Karen, we've actually uncovered a cyst on your ovary. And being a high-risk woman, being 36, you're not having any more children, we actually make the recommendation that you need to have that ovary taken out, also your fallopian tube, and we'll also do tubal ligation. So I went ahead with what he said and actually had that done about a month later. So I'm missing one ovary and one fallopian tube, and on my other side I actually have tubal ligation. I was about 2 months ago about to have my second side done, and unfortunately Professor Quinn hurt his hand and wasn't able to operate, and then with my work schedule I haven't been able to reschedule at this point in time. But I have from that found out that I am actually perimenopausal, and so that puts a different spin for me. And Gillian can explain this, the greatest protection for women taking their ovaries and fallopian tubes out is actually premenopausal. And so I've possibly slightly missed that boat, although they kept telling me not to. So, but it is on my list of things to do in terms of in the new year to actually have the other side out and to actually go through menopause, which I'm really not looking forward to. So if anyone has any tips and they want to share it, I'm happy to take them. So for me, I have a daughter and a son. Nicole has 3 children, and my brother also has, in the last month, actually had his gene test done and actually came back negative. So, but I will stress there was a huge amount of guilt from him in terms of the fact that he didn't have it and us girls did have it. And he had a really long conversation with him, and he has a daughter as well. And he said, I'd rather I had it. He said, you don't get to choose. And it's okay, because we're actually going through the testing and we feel like we're in a position that we have this power and we have this knowledge. So, but there was a huge amount of guilt from his perspective in terms of, the fear that, he should have had it because it wouldn't have developed into ovarian. The poor love didn't think about it passing down to his daughter. So we're happy to say that that's not the case. I guess for me, 4 years ago, well actually 5 years ago, my husband was actually diagnosed with pancreatic cancer and actually passed 4 years ago. So for my children, with me having the BRCA2 gene, and as Gillian has shown in her slide, BRCA2 has an instance of slight raised risk of pancreatic cancer. So for my children, I guess it's really important for them to actually be tested as well. Although I have spoken to many researchers in the pancreatic field, and they believe that it's probably more one-off for my husband, but 51 and 2 days, it was a little young. So I guess from my point of view, genetic testing is extremely important. I'm so excited about the influence of PARP inhibitors and targeted therapies for women who actually have BRCA mutations. I think that is actually really the way that we're going to go forward. I'd actually like to see it moving a little bit faster, particularly from a pharmaceutical company. Obviously from their economics, 18% is actually a very small group. So I guess that's one thing I feel very passionate about, and we have discussions at board level at ANZCOG about the pharmaceutical industry and how they should be investing more into PARP inhibitors and targeted therapies. But I really believe that is the future, and I think it's a really exciting time, particularly with the opportunity to actually discover more genes, because obviously that is the case. We know that there's a lot of women who have family histories but they don't have that gene. So I would encourage anyone, and this is my personal choice and I'm saying to you, is to actually go through a service such as the Peter Mac Familial Cancer Centre. You don't just go in and they give it to you on a piece of paper and you walk out. It's a whole holistic process. They actually do talk to you. They talk about what the impact would be if you had that. If you had that information, how would your life change? So they actually walk you through the psychological process of getting that kind of life-changing information. And I couldn't speak, and my heart goes out to the Peter Mac, because I think they're an amazing facility and they're doing some really amazing things. And I'm very sad to see my friends leave.
It's been a great privilege for us today to hear from 2 incredible experts with 2 very different hats on, but no less important expertise that they bring today. And as Karen indicated, Gillian will be moving to Canada shortly, so on the 14th of December. And so we are very privileged to have her here today, given I suspect that she's pedaling very hard between now and the 14th. So very, very grateful to you, Gillian, for being here today, as to you, Karen, for taking time out of your busy schedule to join us today and to give us 2 incredibly important perspectives on an incredibly complex and very challenging area, but also very promising and with a whole range of opportunities. So I'm conscious that Karen needs to leave in about 15 minutes. So if we kick off questions and think about Karen from her personal perspective, and then we'll turn to Gillian so that Karen can go.
So what we did was, we had a similar situation, and the great thing about the Familial Cancer Centre is it is actually open to direct blood relatives to actually have that testing and to access it. And as we said, it's really important to understand that unless you, as a survivor of ovarian cancer, actually have that test, they won't have access to that information. What we did was I wrote a letter to all my relatives on behalf of my mother, saying that it was her legacy, and it was really important to her that her family could possibly be saved, and that I'm not sure what the numbers were because it's actually a really private process, but I understand from my first cousins and second cousins who have actually contacted me, quite a few actually took it up. So I think my advice to you is that you can only do what you can do. It is an individual choice. Sometimes they're not quite ready, and it takes time, and because maybe as you said, they've been through the process for 3 years with you, maybe it's too raw and maybe they're not ready to do that. So I think you've done your bit. I think it's time for you just to let it be known, and then you step back and let, yeah.
I have to say I agree with Karen. I think our response, as part of the genetic counselling process, it's not just about what the gene is, what genetic testing is. It's also about family communication. And if we identify a mutation in particular, but even if we don't, sometimes the family history is still strong enough that information needs to be passed across. But certainly if a mutation is found, how giving you advice and help to try and disseminate that information. And unfortunately, it does, having the gene test does come with a certain amount of responsibility to inform and disseminate that information around the family. But having said that, I think once you've done that, once you have informed people, my personal view is that your responsibility has been discharged, and you can't be responsible for ensuring that those people then act on that information. I think the thing that particularly concerns me is that people do get informed, but that they still don't really quite understand, and they make a decision not to go and find out more information because they choose not to, but they're not actually making a realistic decision or an accurate decision to not go and find out more information because they've either misinterpreted or put their own interpretation on what that means, and maybe or simply just a bit too frightened to go. So I think the Angelina Jolie and the normalisation of genetics, which is what I sort of alluded to at the beginning, I think has certainly helped a lot of that. That there's a lot of general distrust is sort of is dropping within the community, but it is difficult, and there is certainly consider the concept of readiness, which is really what Karen was mentioning there, that people do come to it at different times. And I can tell you that we've got some families where for a long time the only person in the family file, because our files are all family files, not individual files, for a long time it was one person in that family file, then so suddenly you get a trickle of people coming in some years after they've known that information for some years, and it's taken them a while to come and do that. But I don't think you can do much more other than what you've done. But certainly, all the clinics are very happy to take a phone call from people. People don't have to come in just to get a very bit of basic information.
So my brother was 12 and a half years since my mum passed. So, and 9 months after we had the results. So it's taken him that long. And part of the reason, and we should definitely touch on it, is he's self-employed. And so he wanted to ensure that his income protection and also his insurances were all up to speed. Because there is, although they can't discriminate against you for private health insurance, they will actually give you a higher rating, which is quite ironic because when you actually know you've got the gene, you actually manage the risk. But they actually do put a higher, like I don't have insurance for that reason.
But I have to say that it's actually, the insurance issue is an incredibly complex area. And although Karen said about them putting the insurance companies putting up the premiums, it's not across the board, and I think that's what makes it very difficult from the point of view of in the genetic counselling setting, because there is a lack of clarity in terms of in the impact of genetic testing on insurance companies' decisions. And it's as Karen said, it's not about health insurance, it's not about travel insurance and house insurance. It's about critical. It can be. It shouldn't be, but if there is a problem, then we will actively actively engage with insurance companies, because that shouldn't be the case. But certainly it's about critical illness, it's about trauma insurance, anything, life insurance. There is the Genetic Education Network through the New South Wales Department of Health has got a very good summary of the current status in terms of genetics and insurance, which isn't just for cancer genetics, it's also for other genetic conditions. But the landscape's changed, the rules have changed in recent times, and insurance companies no longer ask about a large amount of family history. They now only ask about first-degree relatives, in other words, parents, brothers, sisters, children. But they do now expect, and stated that they expect, that people will declare if they know if anyone else in the family has had a gene test. They expect to know that information. Now, how they use that information is a bit of a black box, and of course none of this has ever been tested in case law, and that is why it's difficult to actually be very clear about what can and can't be, happen as a consequence of that information. Insurance companies do have a code of conduct that they're not allowed to discriminate against people unnecessarily. They're not allowed to make either inaccurate or exaggerated, put exaggerated weight on information when deciding on premiums. The problem is it's a bit of a black box how they've come to these conclusions. Yeah. And in practice, there has been very few reports of significant genetic discrimination. But the point is, we don't know really how much there is out there, because we only hear what was reported to us.
I've been many times when I was CEO to the Travel Ombudsman and had discussions on individual cases, and there is quite a few. I guess the advice that I got was they will prove that it's something other than having a disease or having an illness. So like you said, it's not tested in a court of law, so therefore it's very suspect in terms of how they present the information back to the client. Yeah. So yeah.
So the one thing, as clinics, we are very happy and do advocate on the part of patients if they are being, if someone comes to us and said we've got a BRCA gene and we're being told that we can't be insured for any cancer. Well, of course that's utterly outrageous, because that is not the issue. Yeah. And we will go back and we will present the insurance company with the actual facts of the matter. And for other genetic conditions, where there's a bowel cancer, because someone's had their bowel removed, that risk has gone. So, and for women who've had their breasts removed and their ovaries removed, frankly, their risk of getting those cancers is now less than the general population of women. So these are kind of things that we actually, it is an educational process. I can actually say that the fear of genetic discrimination is certainly higher than the actuality of it. And also that in Australia, a lot of people choose not to take out insurance. Although there's the general fear, I might not be able to get it. In fact, very few people do actually go ahead and take that kind of insurance out. So again, it's a bit of an educational thing to sort of try, and part of the counselling is to try and put some actual facts around that, put some absolute facts around that, about levels of likelihood of discrimination, because I would hate the fear of an insurance discrimination to put off someone having a test and the absolute power of that knowledge to be denied to the rest of that family. But I agree, it's difficult. So it really comes down to the issue about gene patents. Should genes be patentable? I think actually in practice from this point forward, no genes will be patented, because if you apply the current patent laws, genes should never have been patented in the first place. I think it is generally accepted, although not necessarily spoken about publicly, that the granting of the original patents, if one applied the patent law as it stood, should never have been granted. However, there's a legacy of gene patents,
and it's the US,
most of which, fortunately, are not long off expiring. The issue about new genes being discovered and being patented, I don't think it is going to be an issue. I think the patent attorneys and the patent offices have all been burnt quite badly. But the question is, there's a bit of an issue about what we do about the ones that are still in existence. I think it's, in the end it's going to disappear, and it depends how the patent was applied. Was it to the sequence itself, or was it to how one looks at the sequence? And certainly the way we look at gene sequences has changed dramatically, so we're almost sort of circumventing that bit of the patent because we don't do it in that way anymore. But you've hit the nail on the head, and I think as a society it was completely unacceptable to the idea that our genes could be patented. In other words, the sequence, our genetic code, could be patented, and I think the Australian government heard that loud and clear. The Senate inquiry was very clear about that. The problem is, although one has that general concept that we can all agree to, how do we actually go about applying that? Because then you start to get into the intricacies of lawyers and seeing where the comma happens in a sentence, where the and the but happens in the sentence, and how that changes the meaning of what's being said. And it becomes very difficult to get to the specifics of changing something. And I think in the end, it came down to that. Actually, if you actually apply the law itself doesn't need changing, but a patent has to be something. A patent is only achievable if something is both novel, there's a use ascribed to it, and that there's a third line to it as well. And it had to be an invention and not a discovery, and that was the crucial thing. And there was a lot of woolliness when the first genes were identified, because finding them was we mustn't forget, although we do it now without thinking twice about it, the cleverness of the people that thought up how we could actually find a genetic code was immense, and it took forever, and it was expensive, and it was difficult, and it was time consuming. So the actual effort, absolutely. I don't think anyone quibbles about the method patent, but because the whole thing got muddled up, that the sequence got muddled up with all that methodology, that the whole thing became patented, and that's what's been very difficult to unpick. But now, just finding a genetic code will never be patentable, because it's just old hat. Finding that code now is old hat.
It's still very important from a consumer perspective for consumers to ensure that their representatives know that is the case. That it's actually quite critical, and that's where you have organisations like Ovarian Cancer Australia can assist. Absolutely. And Breast Cancer Network. Yeah.
Just to go back to the question of the test. So in terms of the actual technology of the test, there's two types of testing. There's what we call gene discovery, the gene mutation detection, and then once a mutation has been identified for a family, because most families will have their own unique mutational gene fault. So the first test that's done in the family is to find where in the gene, both of these genes are very large genes, where in the gene is the fault. Once you've identified the fault in an individual in the family, we can then go and test anyone else in the family, whether or not they'd had cancer, for that single fault. So we don't test the whole of the gene at that point. We test is it there? Is it not there?
Can I just add on to that? Is that why you test the person with the cancer first?
Yes. So going back to the beginning. So we test a person with cancer in the first instance in the family, because if anyone has got a gene mutation in the family, it is likely to be that person.
Sorry.
Yes, that's fine.
My mother passed away, so she's...
That's right.
Test her, but you can still...
Yes.
Test me.
Well, so testing, there's two levels or two drivers to the ability to access a test. The first is there a high enough risk to warrant the test in the first place? And the second is a societal thing, which is how much money do we have to put into genetic testing, and how do we allocate those resources in an equitable way across society? So if there were no resource issues, we would still ideally go to the person with cancer in the first instance, because that's still the best person to try and find the mutation in the family. But in the case where some families where everyone has died, or people have lost touch with their family, they're aware there's a family history, but they're overseas or whatever. At this point in time, a publicly funded gene test in Australia is not available to people who've not had cancer themselves as the first person in the family. And it's only because for that person, there's a 50-50 chance whether they've got the mutation that's in the family, if there is one in the family. So if you test them and don't find anything, you can't really interpret that result, because either there's not a mutation in that gene in the family, or there is and they've not inherited it, and you just don't know. So you're still going to advise them and manage them as the family history dictates. Of course, if you do find a mutation in them, really hard piece of information. So it's not that that's difficult to interpret. It's real and it's there. It's about how do we allocate resources when we've got really quite a small genetic testing budget. In the UK, they've just changed their rules, and in the UK, if you get just above a certain level of risk of having a mutation, which is an integration of how strong your family history is, and your relationship to those people, if you get above a certain score, regardless of whether or not you've had cancer, you're eligible for a test. Now, I think in Australia we will change and we will come around, but right at the moment we don't have a funding stream for people without cancer as the first test in the family. Having said that, the testing costs are coming down. So for start, from a public funding point of view, we will probably lower our threshold. But in the meantime, for women who don't fulfil the eligibility for a test, can pay for the test, we can do the test. They just have to pay for it, and then we'll take it from there. But I agree, but the reason that we don't do it is a practical reason, partly because it's more limited in terms of the information it can give us if we don't find a mutation, but also because we don't have a funding stream right now.
And the cost, I assume, will differ, Angelina, by clinic, or
no?
There isn't.
So it differs wherever you go. So the private laboratory at the moment is sitting just over $2,000 for that test. There may be other places, other laboratories. Not that not the main private laboratory in Australia, but some other laboratories might have if you go to different places, have a slightly different test cost. And I think that it's fair to say that it ranges from about $1,500 to in the sort of 2,000s, depending on where you go. So look, it's not cheap, and one of the and so that has to be factored into that decision. But so hopefully that's answered the question. So for the first test in the family, it's easiest to go to the person that's had cancer. There's also, it's not foolproof, having said that, because sometimes, particularly in a breast cancer family, breast cancer is common, so people might not have inherited the family mutation but develop breast cancer, and if they're the person we test, then we'll know further on, but there's a mutation in other people. But we do, so going back to your question, so when we're doing the mutation detection test, if we find a mutation, we always confirm that with another blood sample taken at a different time. So I can absolutely say I can't think of a single, across Australia and across the UK where I was working before, I haven't heard of anyone report that they found a mutation and then went back and tested it and tested again and it wasn't there. In other words, the first one was a mistake. So the finding of something in terms of a false positive, seeing something that actually isn't true, is, I suppose it's theoretically possible, but vanishingly rare in practice, I think is the best thing to say. And certainly when we then go into the predictive test setting, so someone who does have, we know in the family there's a mutation, and someone has got, whether they've got cancer or not now have a test, the presence or absence of a mutation is a real, and again, whatever the result is, whether it is they've got the mutation or not got the mutation, we'd repeat that with a second test again, because of course people are making important decisions, preventive surgery. We don't want people to be doing that unless we're absolutely sure. So just in case, there's human beings involved in a process, could there be a switch being made, we always repeat those tests. Now, going back though to the mutation detection, by far the most common results, so if someone comes in with cancer with a bit of a family history, we do a test, by far the most common result is we don't find anything. So, we probably find a mutation or a fault in about 15% of the people that we test. Now that means, what happens with the other 85%? What means there? Well, it depends on the family history and what our concern was in the first instance. So the chances of us missing a BRCA mutation, a technical miss, is small. There may well be mutations that are not amenable to detection by the current methods that we can use. In other words, the type of technology we can apply at this time, maybe there's types of mutations which get missed by that technology, and we still think there's probably maybe 2 or 3% of mutations are present that our technology can't find. And so the way that counselling is very complex, so we have to explain how confident we feel that not finding a BRCA fault in that person means that they're off the hook, or do we still have to be worried about those families? And how confident we feel about the family being, well, this is probably just bad luck then that this person had cancer and there's not much impact for the rest of the family, depends on the age of onset of the person that had cancer, what type of cancer they had, what the strength of the rest of the family history is. And the stronger the family history is, the younger that person is when they had cancer, the more concerned that either there could be a BRCA fault that our technology couldn't find, that still remains a very small thing, or more likely, could it be a mutation in another gene? So if we're only testing for BRCA1 or 2, but it's a mutation in either BRCA3 or one of the other genes that we know, well then of course we're not going to find it by doing a BRCA gene test. And so that's where this sort of push to try and understand the broader genetics of of ovarian cancer and what other genes are involved, so we can start offering a panel of testing. So instead of just when we do a test for ovarian cancer, instead of it just being BRCA1 and 2, we want to actually expand out. And maybe there's somewhere between 5 and 10 genes that we might be testing for in the next few years, as we get a better handle on what to say to people in terms of those gene mutations. And of course, as new genetic discoveries find other genes, adding those to the panels as well. And it's only because now the technology allows us to leverage the number of genes into a single panel test that's now possible. So hopefully I answered your question that finding something is almost never, I suppose I have to say, never come across a case for false positive. We always check that the result that we have is correct by repeating the test. In cases. Well, the false negative is this idea, as I said, that we're doing a mutation search, so we haven't found a mutation in the family already. We test BRCA1 and 2 and don't find anything. How negative is that result? It's almost certainly a true negative for the BRCA gene fault, barring a very tiny fraction that might have an unusual type of mutation. But could there be another gene fault, a fault in a different gene? That's quite possible, and it depends how strong the family history is. So a negative result, not finding a mutation when you do a mutation search, can have a wide range of interpretations, and that's where the genetic counselling comes in to try and explain for that person how confident are we in the negative. Does it truly mean there is no problem, or is it a problem but a different sort of problem? But the false positive is vanishingly small. False negative is not so much a false negative as in a miss, but it could be another explanation. And the national guidelines are changed so that if you've got an invasive ovarian cancer, not the borderlines, but an invasive ovarian cancer, would now be eligible to have a test purely on the basis of that diagnosis. The only people that are currently sort of just still out of that loop are women beyond the age of 70 with no family history. So they're a relatively small number. Most women will be younger or have a smattering of family history that would be enough to tip them over. So the family history is only coming into play now if a woman is older, quite a lot older when she gets her ovarian cancer.
So it's an incredibly important kind of platform that we're adding to our awareness messaging, trying to get it out there to the community to be recommending that every woman diagnosed with ovarian cancer goes to a familial cancer centre and has a specialist consultation at the very least to explore and start to have some of these important conversations.
And I think it's important.
Very important.
I think it's important to say that coming and speaking about it and getting information about it doesn't mean that someone has to have a test. So coming along to the clinic doesn't mean that someone has to have a test. It's purely just to seek to understand what that means and may choose to have a test. No. So anyone that's eligible for a publicly funded test, there are no out-of-pockets at all. Quite a lot of the genetics clinics run as privatised clinics. In other words, will Medicare bulk bill. But in terms of out-of-pockets, no. So if you're eligible for a test, the test happens. The only people that would have to pay are for those people who don't fulfil, one of the eligibility criteria for the test. They still don't have to pay for any of the genetic counselling or any of those things. It's literally for the physical test.
And you can only talk about blood tests, not by tumour sample?
Not by tumour sample at this time. We hope that in the future we can, which will actually solve a lot of those problems about if people haven't survived. The reason at the moment we can't do a tumour test, and we can for some genes, but not for BRCA1 and 2, is because when you preserve the tumour tissue in the formalin, it breaks up the DNA, and these genes are very, very big, and so because it's so disintegrated, we can't rely on a full mutation screen. But I will tell you that if we know what the mutation is in a family, or if someone comes from a population where there is a known founder mutation. So take the example of a woman with an Ashkenazi Jewish family. If people have died, we can go to the tumour block, take a bit of the normal tissue around the tumour and actually do a point test. So we only look for the faults, either that is known to be in the family or the founder mutations for that population. And we can do a test on the tumour block because that's a specific test for a specific thing. But a big mutation screen we can't do on a block. But I was going to say, not just blood, we can sometimes do it with saliva. For those that are completely needle phobic, we do use saliva. But I have to say, by the time someone's done all the oral hygiene that they have to do for the spit sample, frankly, they're better just putting it on. we've talked so far is presenting the information in a very black and white way. A mutation's found or it's not found. But life is never that straightforward. And that's, those are the clear results. We haven't found anything, we've found something. We've found something we understand and we know is linked to causing cancer. We are all different. I know that sounds silly to say that, but we are all different. So when we talk about the normal BRCA gene code, of course, we don't all have exactly the same BRCA gene code, even if we don't have a fault causing cancer. We have subtle differences in all our genes that are different to each other. So when we do our gene test, what we're actually doing is we compare your gene sequence to what's called a reference gene sequence. And that reference gene sequence has come from another individual with no suspected inherited cancer risk. So we may well find a discrepancy or a difference between your gene code and their gene code. The question is, we then have to try and make a value judgment. Is that gene change cancer causing or is it not cancer causing? Now, some of those are very clear. There's no way that some of these gene changes are compatible with normal function. So absolutely we'll call it pathogenic, we'll call it cancer causing, and we'll use that as a test for the family. Some subtle variations we see commonly enough when we test enough people to say that that's part of normal variation. So it's what we call a common polymorphism, a natural variation of the gene, but we've got a good handle on the fact that it's not cancer causing, just makes us all a bit different. Although it might be different from the original gene sequence. And then we've got a few, the ones that really make us pull our hair out, which we call unclassified variants. They're unclassified. We cannot be sure, are they cancer causing or a rare normal variant? And that's what your letter's saying. They've seen a subtle change in your genetic code. It's not clearly a common difference, which has got nothing to do with it, but it's not clearly pathogenic either. And it makes it difficult. Now, I will say that when we have worked on these one by one, 9 out of 10 of them, in the end, prove to be non-cancer causing. So just by seeing a variation that has rarely been seen before does not mean by default we've got to treat it with suspicion. Actually, by default, we probably should treat it without suspicion. But we just can't be sure. And we then get to the difficulty, because these are relatively rare, it becomes difficult to get enough of people with the same change together to look at their families to try and make a distinction whether or not it is or it isn't. So right at this point, we've got a number of families that sit in this little bucket of unclassified, we're not sure, and we have to wait for what we're sort of looking at the nirvana, which is what we call a functional test. So what that means is that we're able to take that gene change and do a test with it and see what consequence it has on a cell function. In other words, if you put that change, say, into a yeast cell, is it able to grow and divide normally or not? And I mean, that's it in a very sort of crude sense. So if it's a cancer-causing one, and you try and put it in a cell culture of some sort, that cell culture doesn't work properly, and that would give you evidence that it's impacting on the function of that BRCA gene, so it gives us thought and a support and weight to the idea that it's cancer causing. Or if you put it into that cell culture, it makes no difference at all. But we do not have a good functional test, and that there's a lot of time and effort, and that's why I'm saying research is key, to try and get a functional test for BRCA gene variants, because if we've got that, and we do have it for other types of genes that we've got very good functional studies, but not for the BRCA yet. So you've been unfortunate to get a grey result that we can't interpret. And those are the kind of results, just going back to the question before about testing, doing the first gene screen in someone without cancer. Finding these faults are even hard, these unclassified variants are even harder to interpret in someone that hasn't had cancer, because we haven't even got the fact they've got cancer to sort of add a bit of weight to whether or not that might be pathogenic or cancer causing. That isn't a reason why we shouldn't do it. The reason that we don't test someone that hasn't got cancer is often a practical economic issue rather than the interpretation issue. Basically, she goes to wherever suits her best. So whichever the geographical location is where there'll be a clinic that'll be reasonably close to her. If she's an awfully long way away, sometimes we can do things by telephone to a certain degree. it doesn't matter from a family point of view if someone does a gene test in one clinic and they go into another clinic. The clinics talk to each other with the permission of the person that they're speaking to. So we certainly get samples of DNA from someone who's been to the Royal Melbourne. If we've got a family member, we will take a piece of their, well, in fact, we actually do the testing for that isn't a good example anymore. Maybe someone in Sydney had the original test, and we see a family relative down here. We will get a piece of DNA sent to us from the Sydney lab. We will use that as the comparison. The labs talk to each other, that's not a problem. All she needs to do is go and speak to somebody.
The letter that I got back in the late 90s, I distributed to all my family members. I even went overseas and took it.
Yeah.
And I haven't really heard from anybody about this. This is the first time. Oh, my sister went ahead.
Yeah.
So, can they use that letter?
Yes.
Still be valid?
Still be valid. The mutation result is the same, and the important thing about the letter is it will tell them where the test was done. So the labs, again, the labs or the clinics can talk to each other and sort things out from there.
But Connie, did you say that your brother was negative?
No, so now my
He's
brother
not been
hasn't been tested.
Hasn't been tested.
How does
Sorry.
this work?
Yeah.
Does it mean that he has to be tested before she gets tested?
No. Oh, look, no, basically anyone within the family can have a test in their own right. Part of the genetic counselling will be to say, what are the consequences of you having a test on other family members and what that means for their particular risk. So, of course, they do it first and foremost for their own information, but testing your niece without testing her father first, if she's positive, it absolutely tests him. So if she's got the family mutation, absolutely he will have it. So part of the genetic counselling for her, the first step for her would be to have a chat with her about what it means, to put the risks in context for her and explain that's very important fact. What is often most sensible and most efficient, of course, is to test the people in the generation before, because if your brother's negative, none of his children need testing because he can't have passed it on.
That's right. We had a discussion with my daughter and we said, wouldn't it be best if your brother got tested?
Yes,
not her?
it would be, but sometimes people don't want to have a test. They're happy for their, quite a common situation is an elderly grandmother, potentially, and they don't really want to, they're not able to come in and have the test. It's very difficult, but they are happy for the children to be tested, even if knowing by default that will give them the results. And as long as everyone's aware of what those consequences are, there's no problem with that. It's just, I suppose, being an efficient sort of person, I like to think of the most efficient way of going, and it would be best to test your brother. But if he doesn't want to have the test, of course his daughter can be tested. She just needs to be aware of the consequence of her result and how would she communicate that to her father, because of course you can't necessarily hide that piece of information very easily. The first thing we do is provide the person that we've tested with a letter detailing the exact mutation that was found. And that then can be photocopied and sent to all the relatives across the world. Now,
so we won't need communication between the clinics in Canada and clinics?
They do, but it's the family members have to initiate the process wherever they are. So say you have a relative in Canada, you'd give them that information. They would then go, they'd probably go and speak to their family doctor and ask, what are the genetic services available in my area, and get a referral to those services. Once they've made contact with the genetic services and give them that piece of information, I can tell you what happens. Their service would contact our service and we would talk at a service level and give a more detailed information report about the mutation. If necessary, send a piece of the DNA for comparison purposes for a test in that country. So in first world countries, it's not a problem. As long as you've got the information to hand on to other relatives, you give it to them and they access services locally, and then at a service level, communication happens. The difficulty that certainly we find here in Australia is that people don't always come from first world countries, and their relatives are in places where there are frankly not many genetic services, because genetic services in some countries are a bit of a luxury when they're still struggling with basic infectious diseases and basic sanitation, which are much more of a public health program than worrying about someone has a cancer risk that might affect them in 20 years' time. I'm not saying that to minimise the genetics, of course I believe passionately in it, but you have to look at things in a societal sense. So certainly it has been more of an issue, I think, for people who we've identified here. They're able to access preventative healthcare, screening, and they're aware that their relatives might be at risk in other countries where those things are just not accessible. But anyway, if there are services available, we can communicate with them, and you just have to be able to provide your family member with the information, and they can take it from there.
Thank you.
Excellent. So I'd just like to say thank you so much, Gillian, for this morning. It's been so interesting and you've been very, very generous with your time as well. And to, I guess, collectively wish you well in the next phase of your exciting genetic journey of discovery as you head over to Canada. And this year in May, we celebrated the first World Ovarian Cancer Day on the 8th of May, and Elizabeth Ross from Canada was the proponent of that. It was her original idea, and with only a few weeks' notice we got involved in that process. We're now working with Elizabeth and counterparts in other countries to plan for the next World Ovarian Cancer Day on the 8th of May next year, and so we hope that our relationships with Canada will continue to strengthen, especially now that our very dear friend Gillian will be joining the cause over there, and I assume and hope, maintaining very strong ties with us and your counterparts in Australia.
No, absolutely. Still got a lot of research going on, certainly in a clinical sense, strong links. The one thing I'll just one last plea, that in terms of PARP inhibitors, there'll be 2 studies open early next year for women with ovarian cancer. They are exactly the same study, but one is just in women who've been newly diagnosed with ovarian cancer after they've completed their conventional chemotherapy, and the other study is for women whose cancer has come back and they've had another line of therapy for their ovarian cancer. And the trial, as I said, trial design is the same for each. So after completion of the chemotherapy, women enter the study and are randomised to either having a PARP inhibitor as maintenance therapy, so it's a tablet form of medication, or a dummy tablet, so women wouldn't know which one they were on. So all the treatment given as necessary, and then go on to a maintenance trial. So half the women get the medication, and half the women get a dummy, and we follow those women over time. And this is going to the idea of we're moving forward, not just looking at women whose cancers come back. Of course, we're looking in that group as well, but now for the first time, looking in women who've just had ovarian cancer, really trying to see, are we going to change the cure rates of women in that initial setting. So that will involve is women having testing, so that they need to know their mutation status, because of course they can't enter the trial unless they've got a carrier BRCA mutation. But just so if women are linked into their clinics, these studies are going through the ethics process at the moment, are almost through, and are likely to be open in the early new year.
So bring it on, I say.